Go.
Well, welcome everybody to this very special final Friday briefing from Independent Sage. Now, to mark the occasion of this last Indie Sage Friday briefing, we've invited back some special guests, myself included. And this is a special extended session as well. We'll be running for 1.5 hours. We're going to be looking at the inquiry and asking, how can we learn lessons that will make us better prepared for the next pandemic? It's almost 4 years now since we started to hear that patients in the city of Wuhan in China were suffering with an atypical pneumonia-like illness. By early January 2020, public health officials had identified the pathogen responsible, and it was a novel coronavirus. And they'd already released genetic sequences of that virus to the World Health Organization. On the 29th of January, the first 2 cases in the UK were confirmed. On the 14th of February, France announced the first COVID death in Europe. By early March, cases in the UK were surging. By mid-March, Cheltenham races went ahead as normal. On the 11th of March, the WHO declared the outbreak was a global pandemic. By March the 16th, the UK's death toll had risen to 55, with 1,543 confirmed cases. But it was believed at that point that 10,000 people had already become infected. On March the 23rd, Prime Minister Boris Johnson announced the first lockdown. And in May 2020, Independent Sage was founded by the former Chief Scientific Advisor to the government, Sir David King. The rest, as they say, is history. So here we are then with the final Independent Sage briefing, but we're not entirely standing down. Here to tell us more is the current co-chair of Indie Sage, Professor Steve Griffin. Steve, over to you.
Thanks so much, Alice. It's lovely to have you back and lovely to have all of our other guests as well. So just very quickly then, at the beginning of this special briefing, we'd like to emphasise that Indie Sage are not finishing. We are standing down on Friday briefings, and there are multiple reasons that we're stopping this, but we wish to be absolutely clear that it's not because we consider this pandemic to be over. However, it is sadly the case that we now face a drought of directly useful data. We have a continued lack of political interest, and we're in a cost of living crisis. So even though we did go for it last year, we do feel uncomfortable now asking for more crowd funds to support the costs of these live events. And of course, sadly, the pressure from our day jobs does take its toll, and we are finding it increasingly difficult for members of our team to coordinate these. So what we intend to do is to use the remaining crowd funds that we have available to create a lasting, accessible archive on our website. And of course, to maintain our virtual presence. We're not going away. We're planning things like an Indie Sage Substack, some more short format content like the Mythbusters that we did over summer. And of course, we'll continue to comment on the inquiry and ongoing pandemic issues through social and mainstream media whenever we can. So before we get started, we wish to really sincerely thank the public for your generous support over the past years, in particular those who have appeared as guests or asked questions, and of course those who have generously supported our crowdfund appeals. So we hope that you enjoy this afternoon's briefing, and I'll hand back over to Professor Alice Roberts, who will take us forward from here. Thanks, Alice.
Thank you very much, Steve. And now it's time for a summary of the facts and figures. We always start with that. So Dr. Kit Yates and Professor Christina Pagel have been our top number crunchers and interpreters of statistics over the years. And today I'm going to hand over to both of them. And Kit, I think you're starting.
Brilliant. Thanks very much, Alice. Let me just share screen. And let me say it's been an absolute pleasure to share this spot with Christina for the last 3 years and with Duncan more latterly. So this is our last numbers. So what we're going to cover today is positivity, hospitalizations and deaths, and then I'm going to hand over to Christina to take you through what's happening with other respiratory infections, with vaccines, and then just to summarize. And as always, we should say thanks to Bob Hawkins, who's been helping us to collate the data for such a long time now, making our jobs a lot easier. So we don't have a good grip on what absolute numbers of cases are at the moment. The best we have really is positivity data. So positivity, let me remind you, is the number of positive cases or number of positive tests that come back divided by the total number of tests. Now, this probably isn't a great measure over time to compare what's happening now with what was happening 2-3 years ago. But at least in the short term, when testing remains relatively constant, we can say that it at least maybe indicates the trends. So for the last 3 or 4 weeks now, you can see that positivity has been coming down, and that agrees with the other measures that we've been seeing. So let me take you straight to hospitals. Again, this is a look over the last year or so. You can see with hospitalizations, we had this big fall, which was great during the sort of spring and early summer. And then we had this rise over the early summer and into autumn. And then over the last 4 or 5 weeks, we've started to see declines again, which is good news, it has to be said. And that's mimicked if you look at other countries like Scotland, Northern Ireland. They've got similar patterns of declining hospitalizations at the moment. And this is despite the fact that we've got decreased testing in hospitals. I think this trend is still the case, that there is an overall fall. And again, if you look regionally across the different regions in England, the pink bars now are more distant in the past, and the red one is the most recent week. And you can see in almost all regions, we're seeing falls in the number of admissions per 100,000 people in each of these regions. So that's good news. And then I quite like looking at the mechanically ventilated beds as a sort of indicator which doesn't depend on testing. And again, you can see that over time we've seen it mapping up when the cases were up and when hospitalizations were up, but it's coming down now, and that measure doesn't really depend on testing so much. So again, seems to be a good news picture in terms of the direction of travel, that cases and hospitalizations are falling. And similarly with deaths, we reached a peak maybe a couple of weeks ago. Of course, remember that deaths are lagged in comparison to cases and hospitalizations. So we didn't see that peak as early as we did with cases and hospitalizations, but we have reached a peak there. And so I'm going to, I'll suggest that the patterns are similar in Scotland and Northern Ireland as well. So I'm going to pass over to Christina, who's going to take you through some of the data on respiratory viruses and vaccines. Thanks.
Right. So just before I start on this, I just wanted to say, so 2 weeks ago, I presented data from Finland and Sweden saying that they were both seeing big surges. The good news is that both countries have now peaked, although Finland did see the highest COVID hospitalizations of the whole pandemic before it peaked. But now back to England and the UK. So first, this is wastewater from Scotland. It's the only home nation that's actually doing wastewater testing, but you can see trends are down. So that is continued good news as we head into December. From UKHSA respiratory virus report, which is released weekly, this is kind of the 4 major respiratory viruses, especially in winter. So rhinovirus, which is kind of like a common cold, RSV, also a common cold, but more serious in young children and older adults, COVID, and then flu. So at the moment, we're seeing remaining high levels of rhinovirus, although it's coming down, increasing levels of RSV, declining COVID, and flu is going up, but really not very much. So I don't know how big the flu peak will be this year. There will be one, or exactly when it will be, but at the moment, it's still not that common. If we look at hospitalizations, we don't measure rhinovirus hospitalizations because it tends not to cause them as much, but you can see exactly the same pattern here. RSV admissions have now overtaken COVID admissions, and flu is still quite low. So vaccines, we are coming to the end of the most recent autumn booster campaign. And this is where we are. This is data for the over 65s by home nation. And you can see that, uptake isn't terrible. It's highest in England and lowest in Wales and Northern Ireland. But compared to where we were about a year ago, so this is mid-December 2022, you can see in every nation there has been quite a significant drop-off in this year's campaign compared to last year's campaign. And that isn't ideal. Just because it does mean that there will be more people who are less protected against severe disease than they would otherwise be. And this is the whole eligible cohort in England, and their overall uptake is much lower than just for the over 65s, and that's because frontline healthcare workers and immunocompromised people have seen less uptake of the vaccine, and we're at 53% overall, and you can see it's really slowing down now. So I wouldn't expect that number to change very much going forward. And just before we finish on vaccines, I just wanted to kind of have an overview of how many doses our population has overall. So this is for each age group, how many doses, what the uptake is for each of the campaigns that we've seen. This is from the very first dose back in the winter and spring of 2021, right up until this autumn booster. So for the over 65s, the over 75s have had access to all of these 7 campaigns now. And you can see the uptake has been good, but has been falling, but still remains about over 70%. The 65 to 74-year-olds have not had the spring boosters, but they've had the autumn boosters. And again, you can see uptake is okay, but it is dropping. 50 to 64-year-olds have not had access to vaccines since I think September 2022, which is this campaign. Uptake wasn't great, it was about 50%, but most of them, 80% of them, did have 3 doses of the vaccine. For 18 to 49-year-olds now, most of us have not had a dose since the winter of 2021-22, and uptake wasn't great then. So actually they're about 50% or lower of adults who've only had 2 doses, and some still who haven't had any. And for children, uptake is really much, much lower. Hardly any 5 to 11-year-olds have been vaccinated. And about half of 12 to 17-year-olds have 1 dose, fewer have 2, and hardly any of them have 3. So we do see quite a different pattern of vaccination in our population as we go forwards. And just a reminder that most under 5s are currently not eligible for a vaccine, although 1 has been approved. So with that, I'm just going to summarise. Oh dear, this is all gone a bit wrong, right? So COVID positivity and hospitalizations are falling steadily, and deaths are now falling too. The COVID infection survey results, best results, are due this month, I think in the next couple of weeks. So that will give us really the best idea we've got of prevalence across the UK that we've had since March. So I think that's going to be really important information as we go into Christmas. RSV is rising and hospitalisation rates for it are now higher than COVID. There's still plenty of rhinovirus, which causes a common cold around, and hardly any flu, although it is showing a small increase. Autumn boosters are underway, but I think uptake's kind of stalled. It's about 50%, and it is much lower than last year. So this is the last numbers briefing, but we will be sharing numbers updates regularly on social media. Kit, Duncan, me, and Bob Hawkins all have Substacks. Bob is actually going to be doing a weekly detailed updates of these numbers across this winter season. I've put a link to his Substack there. So if you really want to see the numbers, I would really recommend you sign up to him. But I think all of us will be sharing numbers on social media and on Substack. And we're also, I just want to say before we finish, we're trying to do a survey to understand a little bit about the impact of Indie Sage. So please do, if you have time, take 10 minutes to fill it out. And on that, I will hand back to Alice.
Thank you very much, Christina, and thank you, Kit. And I think, once again, what an impressive and clear summary of the data, and really just captures the importance of having people like you, experts like you, who are able to so clearly articulate this data and share it. And thank you for everything that you've done in that way over all of the years. Now we have some more special guests. Professor Susan Mickey is going to talk to the founding and subsequent chair of Indie Sage. So Professor Sir David King is with us today, and Professor Deenan Pillay. And we're going to be hearing about the reason behind Independent Sage, because we've been hearing some voices recently, some bad actors, I might say, that Independent Sage was put together in order to oppose official Sage, and that wasn't the case at all, as we're going to hear. Over to you, Susan.
Thank you, Alice, and delighted, Dave and Deenan, that you could join us today. So firstly, Sir David King, can you tell us why Independent Sage was set up?
Well, I think, first of all, many of us were aware of or felt that there was a very poor handling of the pandemic in the early months. I think that was a major reason. But the second reason was that the membership of SAGE, the official body and its committees, wasn't even known in the public domain. It was kept out of the public domain, apparently to protect members of the advisory committees in some way. And we certainly felt that the public needed a voice from the experts. And so setting up an expert advisory body was really to reach out to the public, but let me say as well, to reach out to members of the government in order to explain in the sort of detail we've just heard, but the sort of acceptable detail we've just heard, what was actually transpiring. I think when I was Chief Scientific Advisor, and I know it's dangerous to hark back to those times, but I was put in charge of the foot and mouth disease epidemic by Tony Blair out of sheer frustration because the epidemic was getting seriously out of control. It was increasing exponentially in terms of the number of farms in the UK going down with it. And it looked as if we were going to have to cull 50% of the animals before we'd get it under control. And so I had independently formed a group rather like this group, Independent SAGE, of experts who could advise me. And then I went in to see the Prime Minister to say what we should be doing. And in his autobiography, he says, this was the first voice I heard of sanity saying there is a way through it. And so he simply handed the task over to me. And I was then the person who went on television and radio very frequently, but without a Prime Minister at my side. Now, you could say I wasn't protected, and of course I wasn't. And if it all went haywire, then I knew it was my job and my reputation on the line. But so be it. This was a serious situation. So I think from that, and also from the fact that I subsequently, and in a way this is important to what we're about to talk about, I subsequently set up a foresight group to look at the future containment of infectious diseases. And we looked at infectious diseases in human beings, in animals, and in plants, and we did that deliberately, knowing that there are these so-called zoonoses, that diseases can transmute and become transferable to human beings from animals. And we had 320 members of that group, the largest foresight group I ever assembled. And we brought in members from China and Africa because we were already worried that this would be the source of a new pandemic. And we set out in that document, which is still on the Government Office for Science's website, we set out what we thought could happen. And we were predicting that a pandemic almost exactly of the kind that occurred would happen before 2030. And we set out strategies as well. Subsequently, I worked within government to see that we had strategies to deal with this. And unfortunately, the memory of these strategies had somehow disappeared. So these are the various reasons that were in my mind. And let me say, the mode of handling a pandemic of this kind, which is known to the entire community sitting around this group here, is, of course, to find, test, trace, isolate, and support. This became our mantra because it didn't seem to be an understanding from what was emerging from government decision-making. We were never designed to be critical of SAGE. We were always giving advice on the basis of what we felt the position we were at in time, and then what should be done going forward from that point. We weren't looking backwards and being critical. So I think it is important to say, no, we were not there to put down SAGE at all. We were there to reach out to the public and explain with a knowledgeable base what we thought should be done and what should be happening.
Thank you. That's really important and interesting to hear about the history. And I think another thing you did was to select quite a wide variety of different academic disciplines, in that, everybody had something to contribute. And we really do need to listen to a wide variety of scientific voices when one thinks about something as complex as a pandemic.
And with a pandemic, it's also, if I can say it in addition, it's critically important to have a significant representation from the healthcare community. And that, I think, was a missing parameter in how the issue was being governed.
Indeed, and we have clinicians as well as researchers amongst us, and over the last 2.5 years have learned a huge amount from each other. Deenan, can I turn to you now and ask you, reflecting back over these last 2.5 years, what do you think Independent Sage has achieved?
Well, first of all, thanks so much for, it's great to see you all, and thanks for inviting me back. It's an honour to be here amongst friends. So I think two main things we've achieved. Firstly, is we've created a model of how scientists across disciplines can come together in a dynamic way, and in a way focusing on public engagement and policy development based around science to respond to, in this case, an emergency. I know since we founded Indie Sage, and Dave has just talked about it, that Dave has led a similar sort of structure with regard to climate change. And I do think we are unique in the way that we have undertaken this task. It's interesting, there's certain characteristics, I think, that have made this group so successful. Not only are we across disciplines, but whether by default or by design of Dave and others initially selecting all of us along the way, is that there's a level of trust, mutual learning, which allows us all to speak with more confidence about areas that are not precisely with our domain. And that is exactly why a cross-disciplinary approach needs to be fostered and needs to be used to make sure that we engage with the public and policymakers. So I think that's the first thing, a model, a really unique model for the future. And I think the second thing that we've got to be really proud about is, in my view, the existence of Indie Sage has really contributed to a much deeper public understanding of the pandemic we've just been through than would otherwise have happened. That doesn't just mean people listening to our Friday briefings. I think our existence has amplified the public discourse. It's engaged with the media. I would say the media, and we all know, since many of us engage with the media with interviews and so on, is I think the media have upped their game, and the level of scientific journalism has improved within the UK media compared to pre-pandemic, when I think we were way behind other countries such as the US. I think now there's a level of sophistication and a trust in public understanding of science, which will both benefit the media. It will certainly benefit the population of the UK when new scientific challenges come forward. And the idea that we may have sort of compromised in a way messaging from Sage or any other structure is, I think, the complete opposite. Is the best understanding of science comes from hearing debate, hearing discussion, and that is what we've contributed to. So that's what I'd summarize as I think the long-lasting legacy of us, Indie Sage.
Thank you, Deenan. And I mean, Dave referred to trust in terms of speaking directly as a chief scientific advisor to the public. You've talked about the importance of trust, of hearing messages. And certainly the data show that the public have much greater trust in scientists than in politicians. And we know from the experience of the last almost 3 years that trust has been an incredibly important part of pandemic management and will continue to be. What you said also raises an issue about scientists communicating with the media and with the public, and scientists themselves have differing views on this. So we heard in the inquiry that Sir Patrick Vallance, the chief scientific advisor, suggested that scientists should only talk to the media about issues that they're directly studying, and that those who serve on an official government body such as SAGE shouldn't also be on bodies such as this that is communicating directly to the media and to the public. Many of us, or several of us anyway, here today have also been part of SAGE. I've never seen any contradiction whatsoever between the two roles, very complementary in my view. And in terms of the scientific advice, very rarely differed. But what's your reflection on this bigger picture? Because I think there's a slight danger about scientists who are advising government really not being allowed to communicate to the public or to the media outside of their very narrow range of inquiry.
Yes, so as you'd expect me to say, I completely disagree with Patrick Valence's viewpoint, but a couple of points really about trying to understand why he and others in his position have said that. First of all, something a little bit more philosophical, really, and there remains, however much we talk about welcoming multidisciplinary, cross-disciplinary thinking around all scientific issues, nevertheless, the main scientific research paradigm, I think, within Anglo-Saxon sort of tradition, really. And I'm thinking less about the social sciences, more about physical and biological sciences, is for people to focus. And that's what we're all taught at university. Focus on your specific area. I mean, I remember as a PhD supervisor, really pushing my students, don't be too broad, don't get waylaid with this, that, and the other, focus on your question. I'm sure we're all familiar with that. And the current hierarchy, what I'd call the scientific hierarchy, government advisors, the royal colleges, royal societies, and so forth, are still really fixated on focused science as the pinnacle. And I think that's where Patrick Valence is coming from. SAGE, as many of you who are involved with SAGE, and I have been in the past, people are selected, particularly, again, outside of the social sciences, and putting modeling to one side is we want the best mucosal immunologist. We want the best B-cell immunologist. We want the person who understands viral replication most. That is what focuses. And those are the questions that are then being asked of those individuals. So I think there's a philosophical underpinning to stay in your lane type of thing, which really reflects something about where those individuals who are at the top of the tree have come from. And secondly, of course, what follows from that is this false dichotomy between scientists giving scientific advice and political and policy decisions being made of it, and that there shouldn't be a divide between the two. And that also speaks from putting myself in the position of Patrick Valence or Chris Whitty or so. That speaks to let us be pure with our science, and let us not get our hands dirty with things that are a bit messier. Those of you in more social science, always getting your hands dirty. I appreciate that, but in terms of biological science, that's certainly you've got to keep things. So that's where I think Patrick and colleagues are coming from. But the reality is completely different, as we've seen from the pandemic. The scientific illiteracy of the civil service and politicians have just led to huge frustration on behalf of Patrick, Chris, and others to actually get their message even understood in the most trivial way, let alone the most profound way. And so I think, despite that, Patrick Valence still talking in those terms, I think the reality now is, of course, we need to speak our minds, and we need to think about and be encouraged to think about the implications of our expertise and what we think, but equally to work, as I mentioned before, within cross-disciplinary teams, so that we can start to be confident about speaking of things that we'd not directly researched, because of course that is we're able to bring our intellect and experience and so forth to that. So I think Patrick is wrong. I understand why the current structures are such, but I really hope that as one of the outcomes of this inquiry is the appreciation that in fact that model is incorrect. There needs to be far more practitioner-based people within the advisory structures, but also there needs to be a growth of a more scientific literate sort of culture within the civil service. I should finally say, though, and it is interesting that with regard to stay in your lane, the people who've drifted most out of their lane have been, and I've learned, and have been they've been held to account by members of this group, are Chris Whitty and Jenny Harris talking about behavioural fatigue, and this demonstrates that, of course, people get out of their lane, but if you're going to get out of your lane, you've got to understand what you're talking about. I'm glad that Chris has had the grace to apologise to the inquiry about that. We await Jenny Harris' apology. I see she'd sort of avoided that in the inquiry. But I would just say I'd hope that we move to a different place. And again, Independent Sage has been critical in pushing that agenda forward.
Thank you. And I think if one is going to get out of one's direct lane to talk about issues, then consult with many different lanes before talking. And that's something that we've all done. And had Chris come to the Behavioural Science Advisory Group that myself and Steve Reich were on, he may never have said what he said. The other thing I just want to reflect on, very interesting, isn't it? When we write our scientific articles, in the discussion part of our articles, we're always asked to speak about the policy implications of our findings and the practical implications of our findings. That is just good practice and what we're asked to do. But yet, as soon as we step out of our articles that are published in the academic journals, we suddenly told, no, you can't talk about the practical and policy implications of your science. Very strange. Moving on, and finally, is the last question. Dave, to you. What are the lessons for the future from the experience of Independent Sage in your view?
I think the first lesson is that we can be awfully forgetful. We could set up a commission of inquiry, we could draw conclusions from that, and then it can easily get lost in the system that is government. So we definitely need to find a means of maintaining the memory of lessons learned and also of what we didn't do right, so that next time round we actually do perceive the mistakes that can so easily be made. What this discussion is already setting out the fact that we need scientific voices in the public domain. It's critically important, in my view, in a period of a pandemic or something similar to that, to keep the trust of the cabinet and the government, and at the same time keep the trust of the population. It's not that difficult. We mustn't be afraid of saying, well, we've got to talk quietly to government and let government ministers try to interpret what we've been saying. We need to see that government advisors in science do have the ability and right to go with their independent voices into the public domain, understanding that they've got to keep the trust both of the cabinet and of the public at the same time. That's quite a challenge to bear, and I've been there, but it's really important to do it because it raises the population's trust in the government as well as in the scientists. So there's that. And the second, of course, is we already have a real knowledge about dealing with epidemics. The experts who go out from the Western countries to Western Africa when there's an Ebola outbreak, and they sit down and manage those outbreaks extremely efficiently. And I think this is something Anthony Costello would comment on. So we already know how to handle pandemics, and we also know that going into lockdown is an absolute last resort. And I've got one third lesson to learn, which is we have a wonderful system. It's called the NHS and the GP services, which exist in every part of the country. And if we want to start testing people, which we ought to do in such a situation, and we want to do it effectively, it's got to be done through those bodies. We're all close to GPs. One of the big mistakes was setting up private companies that had no knowledge of healthcare to provide the testing capability, which never delivered. And many people were being asked to travel hundreds of miles to be tested. Quite absurd. So there are quite a few lessons learned from mistakes made.
Thank you. And you're so right that we need the mechanisms and the structures to carry the lessons learned forward. After the 2009 pandemic, I gave evidence to the Deirdre Hine inquiry, and the report came out with some very good recommendations. Have we heard about this in the inquiry this time? Have we heard about this in the last 2-3 years? I haven't. What's happened to those recommendations? So important that that doesn't happen again, that whatever comes out of the learnings from what you said now, Dave, from all the other different, the inquiry and all the other different organisations that are learning lessons, that these are taken forward. It needs structures and mechanisms. It also needs political will. With that, Alice, I'll hand back to you. And thank you again, Dave and Deenan.
Thank you very much, Susan. And I have a perspective on this as well, because obviously I work in the arena of public engagement in science, and really some of the points that were just made in that conversation between the three of you really stood out to me. I think for me, looking at Indie Sage during the pandemic, and my own kind of personal experience of that, but also looking at what the public have said to us and the feedback from the public, I think there are three things that have stood out to me as really important. I think, as Sir David showed us with his examples, I think that in any situation, especially in a crisis, we want to be able to make the best use of science. Science is quite clearly the best way we have of understanding the world around us, but it doesn't help us much unless we can put that knowledge to work to make it effective. And David King talked about some great examples there about how you can identify and then spread best practice. And as you said, Susan, make sure you retain that memory as well. And secondly, we know that communication between scientists and the public is crucially important. There are decades and decades of research that show how this works best as well. So there's a really good evidence base for this. And we know that crucially, openness and transparency is really important. It leads to better understanding and then better decision making. This is all about decision making. It's all about real world impact of that science and that communication. So communication is part and parcel of good scientific practice. And studies have shown time and time again that you can present scientific facts, and that doesn't engender trust in science and scientists. Just putting the facts out there isn't enough. Some studies have shown that education is important in whether or not people trust science and the level of education that people have. But in fact, it's not the main factor at all. It's basically, it comes back to the scientists themselves and their willingness to engage, to listen to people, to be seen to be human, to have a dialogue, to empathise. That is absolutely crucial. Science isn't just a body of abstract knowledge. It is people who are doing it. And you keep trust through openness and honesty and humility. And we've heard a bit about that already. Thirdly, I think there's a philosophical and a moral dimension to this. I think there's a really profound belief here, a profound moral belief, which is about the role of scientists in society. The fact that scientists have a moral duty even to engage with the public, not just to be getting on with their science in their labs, but to be out there talking about it, to engage with the public and policymakers, and to make sure that science is benefiting everyone in society. Otherwise, what is the point? And like Susan and Deenan, I think Patrick Vallance was wrong, simply wrong about engagement. As a professor of public engagement in science, it was really dismaying for me to hear that view. I don't think at all that scientists should be retreating inside the ivory tower, slamming the doors and only talking to policymakers and not talking to the public. If you're in a democracy, that is not even an option. It is not ethical to be depriving the public of direct access to not just scientific facts and figures, but to scientific discussion, especially during the pandemic in that fast-moving situation. So if I think about these briefings for a minute, these Friday briefings, they provided an opportunity to share up-to-the-minute facts and figures, as we've had today with Kit and Christina, every week and then every 2 weeks through the pandemic, to share expert perspectives on how different mitigations might work, both personal measures and also societal measures, and then answering questions and listening to people. Time and time again, I heard from the scientists on Independent Sage how important it was for them to understand the public's concerns. And in a time of crisis, it just felt like the right thing to do for scientists to be sharing information directly and to be open to having these conversations with the public and to be empathizing. So next time around, the next pandemic, I'd like to see more effort to create room for conversations like these between scientists and the public. And it is about making sure that we're maximizing the potential of science, because if we don't grasp that, it can have devastating consequences. And we've seen some devastating consequences through this pandemic. We need to be working on it right now. We can't just wait for the next pandemic to come along. We need to be looking at enhancing public engagement and seriously investing in doing that. And as Sir David said, we must learn lessons and we must remember those lessons, as Susan emphasised as well. So we need to make sure there's a good relationship between scientists and the public, between the whole worlds of scientific research and the public. And it goes for all aspects of science. Science is informing so many different aspects of our lives. And I think universities have an absolutely crucial role to play in that. So I think Independent Sage, for me, is an excellent example of public engagement with science. We know that from evidence as well. We have so many people who have given us feedback over the years that they've hugely valued that opportunity to access science and scientists, to ask questions and to be listened to. And of course, we are going to be doing that today. We are going to have some public questions. But first of all, I would like to thank Susan, David and Deenan for that fantastic discussion to start us off with some historical context and quite deep thinking, I think, around public engagement with science. Now we're going to focus on behaviour. Now, there were around 8 members of Independent Sage that formed a behavioural subgroup who then advised the main group. And we're going to hear from Professor Liz Stocko from that behavioural subgroup. So over to you, Liz.
Thanks, Alice. And I will just share my slides. So the Behavioural Advisory Group of Independent Sage was set up in May 2020 in recognition of the crucial role of behavioural and social science in the response to COVID-19. Members' names are all here on the slide. Mostly we're professors of disciplines like psychology and anthropology. Some of the members were also on the behavioural subgroup of SAGE called SPI-B, or other SAGE subgroups, performing what we saw as a complementary role, putting forward evidence-based proposals for combating the spread of infection and evaluating government policies and messaging from a behavioural science perspective. Some of our members appeared regularly on IndieSage briefings and in the media, explaining how best to control infection rates and minimise the distress and disruption caused by the virus and the measures needed to combat it. An early piece of our work focused on the links between UK government messaging about COVID mitigations and their association with public understanding and adherence to them across a timeline. 2 further key pieces of work undertaken in collaboration with other experts and organisations, with the development of a scheme to provide clear and accessible information about ventilation and clean air, and the COVID Safety Pledge, designed to give workers, service users and customers confidence that they can use spaces like shops, restaurants and offices safely. We also developed a behavioural science timeline in which we mapped the main recommendations about COVID mitigations from both SAGE's SPI-B and Independent Sage's behaviour group against what the Westminster government actually did and when they did it. And this clearly shows that, contrary to claims that have been made that Independent Sage was in some sense a challenge to SPI-B, we were in fact able to amplify and communicate its key findings to the public. Looking to the future, it's clear that a successful response to COVID-19 type events depends on multidisciplinary expertise, including the behavioural sciences, so that key issues like resilience, social justice, inequity, public trust and confidence in government, communities and partnership are all part of a coordinated response. And fostering a genuine partnership with the public is what Independent Sage has sought to do over the last 3 years. And I'll stop there.
Thank you very much indeed, Liz. Independent Sage is all about engaging with the public, listening to concerns and questions. So we have got some questions from the public now. We'll start with a question from Lynn Rose. Thank you very much for your question. Is it known what the risk is of developing serious health problems as a result of an infection? Who would like to start with that one? Do we actually know what the kind of long-term risk is? We know that COVID isn't just something that is there and then disappears. So can I have a member of the panel to start with this one? Anthony, are you offering?
Benita is.
Benita, would you like to start?
Yeah, so I think we can look at this in 3 different sort of segments, really. So you've got the patients who had acute severe COVID and were hospitalised and now have longer term impacts of that acute illness. We've got a group of people who had a fairly mild infection at the start and then have ongoing chronic illness, which can be multi-system and very disabling. And we think there's about 2 million people affected, of which about 500,000 are still significantly disabled by their symptoms. And there's a third group where they have an infection, they get better, but actually the virus has silently caused some damage to the internal organs. So you can see now in quite large studies that just even having the virus itself, even if you've completely recovered, can lead to long-term organ damage and increase your risk of cardiovascular events. So from a population perspective, we already have a fairly unhealthy population who have now had repeated infections with a virus that can cause ongoing impact to the blood vessels and vascular risk. And I think this will all unfold over the next couple of decades to see what the totality of the last few years, what impact that has had.
Thank you very much, Dr. Benita Kane. And Steve, you'd like to comment on this as well?
Yeah, so I think this is a really important point because we still, as well as the long-term problems that Benita's just talked about, we still have a problem with acute COVID. And whilst this isn't happening in these massive peaks that we saw prior to the era of vaccines, and vaccines have done a fantastic job of reducing that. Remember, there are other countries across the planet where they're not as well protected. But we are still seeing a huge degree of mortality as a result of acute infection from this virus. And the difference between this and something like influenza is that COVID tends to be the underlying cause in those deaths in something over 60% of the cases, whereas in flu, it's far, far lower than that. And that's because we are still seeing serious complications from this virus. And even though we've not seen them big peaks and we've dropped from something like 80 or 70,000 deaths in 2020, 2021 to 30-odd thousand in 22, we've still seen more than 16,000 deaths on the death certificate attributed to COVID this year. And that's, not all just vulnerable people. So this virus still is serious, it's still a cause for concern, and it still causes tremendous NHS pressure in the acute phase. So I hope the winter doesn't bode ill as we saw last year.
Thank you very much, Benita and Steve. We've got another question from a member of the public here, Nicola Pocock. A very specific question about viruses here and about vaccines. Do you know if JCVI are considering approval of Novavax's updated XBB monovalent vaccine for winter 2023? as data on this vaccine looks promising regarding the durability of protective effects. Do we know then, have we got any hint of whether JCVI are going to recommend approval of that vaccine?
Shall I take that? Shall I just start? So you're absolutely right.
Yes, please do. So yes, Sheena. Yeah, over to you.
Sorry. You're absolutely right. Novavax, it's a protein-based vaccine, and it has indeed shown some very good results in trials, and potentially does look like it gives us some more durable immunity. Now, that vaccine, the Novavax platform, was approved by our medicines and products regulatory healthcare industry back in 2022. And they're the ones who actually make decisions. And similarly, it's also been approved by the European Medicines Agency and the WHO. I am not clear why this has not then translated into purchase and use. I've gone through the JCVI minutes in July of this year, for example, about their booster plans, and it suggested that this year they were prioritizing vaccines that had already been procured or in the process of being procured, which was basically the mRNA vaccines, and that was to ensure that they were able to deliver the autumn booster schedule. I have not seen anything in their notes about a sort of longer term approach, bringing in Novavax or even other types of vaccines such as mucosal vaccines.
Thank you very much, Professor Sheena Cruikshank. So yeah, a little confused on that one. Not that Sheena is, the response seems a little confused, given that it seems like a very good option. So we have a final question from the public, and then we're going to move on to some frequently asked questions, which Steve is going to chair. But this final one from the public is from Anne Ashworth. It's a big one, so we better deal with this briefly. And I'd like to hear from maybe a couple of the panel. How and when is the COVID-19 pandemic going to end? Polish up your crystal balls. Who'd like to start with that one? Susan, did you bid for that one?
I didn't.
You didn't.
I'm probably the least qualified to know what the answer to that is.
There's so many people today. I'm trying to keep
Aris, I think Aris is there.
I can make a start.
Aris, go ahead.
So I think that unfortunately the short answer is we don't know and we don't know. And the reality is that it's going to be some time until we know when it will end and also what the end will look like. Because to talk about an end, we need to have entered a period of regularity. And I guess from my perspective, a cessation, a stopping of out of season peaks. So we're still seeing unseasonal peaks of spread of the virus in the summer, for example, and we don't know where and when those will arise. So some kind of endemic equilibrium, a sort of regularity of pattern that doesn't have these out of season peaks will be the point at which we can talk about an end. It doesn't necessarily mean it will have gone away as a public health problem, but it does mean we'll be talking about an endemic situation. But we'll need to have gone through at least a year of that before we know we've even hit that point. So I think we won't know when the pandemic has ended until it has already ended for quite some time.
Aris, do you think it will end though? I mean, do you see an end in sight?
It's a really difficult question, and part of the answer will depend on what we do regarding immunization. I think it can end, and it can end quickly if a new generation of vaccines comes along quickly. If we still continue to rely upon the current generation of vaccines, do not innovate or update and continue rolling out, and simply rely upon wave upon infection for acquisition of immunity, that's another story, and that may well take a very, very long time indeed.
Thank you very much, Professor Aris Katsarakis. Now, Aris is a professor of evolution and genomics, so he has this kind of long view on viruses do. So thank you very much for answering that question from the public. And now it's time to look at some of the aspects that have sparked most of the questions from the public over the years, as well as key points that are emerging from the inquiry, which is obviously still happening. We want to know how we can learn useful lessons from the pandemic and implement those in the future. So over to you, Steve.
Thanks, Alice. So this really is about sort of, as Alice just said, gathering all of our thoughts together and trying to put it into a coherent package for posterity, maybe. So we decided to do this because earlier this year, of course, the WHO, ironically, in light of the last question, called off the international emergency with respect to COVID. But this is more a logistical step than any sign that the impact of this disease has really diminished. And we know this because we know that confirmed mortality, so where there's been a test linked to a death, is somewhere around 7 million across the planet. Yet some of the best models show that the real toll from this could be anywhere from sort of mid-20s to the low 30s in terms of millions of deaths. And unfortunately, of course, morbidity is a major problem as well, but this will continue because the burden of infection has shifted from richer, well-vaccinated countries to the lower and middle-income countries across the planet. And as I mentioned, the morbidity, and as Benita has told us, the morbidity associated with this virus infection is vast. WHO estimated in spring that something like 17 million people had experienced long COVID. We have around 2 million in this country on its own. So this really is a long-term problem that we need to sort out. And yet we're told consistently in the UK that COVID is over. And unfortunately, we therefore count the cost of this ignorance at the population level in terms of deaths and morbidity. And we have literally virtually no mitigations remaining in place now. So as the inquiry on goes, we decided to put to our panel a sort of key question, which is that most agree that things could have been handled better here in the UK. But now, with the benefit of hindsight, what have we learned? And we're going to start with just before the pandemic, actually, because previously the UK was ranked second only to the US by many in terms of its ability to cope with a pandemic. But Professor Martin McKee, will we really this well prepared in 2020? Or if not, why not?
Well, in some respects, the UK was well prepared. We had world-leading science, for example, in genomics, and we had a plan, just that it was, of course, as we now know, the wrong plan. Now, it was the Global Health Security Index that ranked us second after the United States. That failed to take account of two things. It collected a great deal of information on surveillance and laboratory capacity and so on. But what it missed was the legacy of a decade of austerity that left our national infrastructure crumbling, and in some cases, literally crumbling, and it left our social safety net shredded. And the second, of course, which we've been hearing about in great detail in the inquiry, was the totally chaotic policy context. We had political leaders who were bamboozled, and we had their aides who hated each other, and in almost all cases had no interest in learning lessons from elsewhere. And unfortunately, this is what happens when people are chosen for their loyalty rather than their ability. The one positive thing to come from this is that we now do have a much broader concept of resilience. And of course, most of my work is outside the UK. We've been doing work with WHO, European Commission and others, looking at how we can build in all of these lessons. But I think the challenge for those of us in this country is how do we achieve it in the political system that we have?
Thanks, Martin. Yes, really, really important points, and something that, the people that just blame the pandemic as in general for the problems that we're experiencing at the moment really aren't giving us the full picture, are they? So moving on now then to the beginning, the very early days of the pandemic, when we just heard about the virus originating in China, about it was potentially spreading around the world. And yet in the beginning of January and February, we had our Prime Minister missing multiple COBRA meetings and things. And Martin's mentioned the approach that we took. But now it's great to welcome back Gabriel Scally, Professor Gabriel Scally. And I just wanted to ask you, Gabriel, what more do you think could have been done in terms of using our testing and tracing capabilities that wasn't done perhaps?
I think to follow on from Martin's very wise words, we could have had a plan for using laboratories, and we could have had you would think that a plan for infectious disease outbreaks would consider the issue of laboratories and what capacity there was, and also the issue about multiple use. For example, I know many countries repurpose their veterinary testing laboratories to do human testing. And that's a good example of the sort of One Health approach that we should be taking, particularly around this this whole arena of dangerous infectious diseases, which could arise in the animal population as well as the human population. So we could have been planned better for it. When we didn't have the testing, I think it was enough tests available. I think it was appallingly handled. What we should have done is rely on clinical diagnosis. We had a good symptom list, and we could have just practiced good medicine, really, and diagnosed people on the basis of the symptoms and taken the important action that was needed about isolation and tracing. Why didn't we do that? Why didn't we rely upon our primary care teams to do that? And why didn't we use the local resources that we had? And I absolutely take Martin's spot on. We'd seen a hollowing out of the state, particularly in England, with the removal of the regional structures, a lot of the local structures, huge funding of local authorities, a really diminished public health response available, particularly in England. But we did have directors of public health right across the UK, apart from Northern Ireland, right across Britain with directors of public health, and they should have been given the responsibility of leading, and they weren't. Instead, it was given to a centralized organization, and that hyper-centralization is a theme, I think, over the last 10 years of what has happened, and it leaves you extraordinarily vulnerable if that central organization gets it wrong. And I think the other thing, and Ante Costello was absolutely completely brilliant on this, because he talked about find, test, trace, isolate, and support. And he was the first person, I think, that put it together so well that it's an end-to-end process. And instead of that end-to-end process, which including helping people isolate, support them in isolation, and then go finding tests, not just waiting for them to come to you, people who needed testing, but that whole system should have been dealt with in a completely different way. Instead of that, we had this, it was just reduced to the labs, basically. And we didn't put a find, test, trace, isolate system in place, and we suffered badly from it.
Thank you, Gabriel. Yes, you're right. We could have done so much more, and other countries did so well with that. And for the record, whilst not dwelling on it, many virology labs did offer to be involved with that sort of effort back at the beginning, but never mind. So right back at the beginning, we talked about approaches, and as the scale of the outbreak became clear, we started to hear this term herd immunity being bandied around by both people in official capacities and in other walks of life. Now, one reason for this was for slowing the infection down to prevent the NHS collapsing, was one way of doing it. But also later on, it was really a way of segregating the population so that some can carry on while others didn't. But I was going to ask Professor Sheena Cruikshank here about this idea of herd immunity by infection. Sheena, could this really ever worked without a vaccine?
Well, I mean, that was the thing. We didn't know. And to be perfectly honest, herd immunity without a vaccine is incredibly dangerous and, in my opinion, unethical. This was a new virus that was already causing severe mortality that we were seeing in China, we were seeing it in Italy, and it was overwhelming hospitals. So we could see what was happening. The shocking images should have been a warning to us here in the UK. Furthermore, previous epidemics with related viruses, such as the virus that caused SARS, had also shown us the risk of high mortality, but also long-term sequelae, because we saw that although it was fatal in around 1 in 10 people, it affected some groups in a much more long-term way. And obviously some groups as well were disproportionately affected, so we could see that kind of difference happening in populations. So all the warnings were there that herd immunity by infection was risky, it could overwhelm hospitals. And of course, we saw the risk of lots of people getting COVID in that first wave, because unfortunately, we got a lot of people developing long COVID as a consequence. It shouldn't have been something we ever considered.
Thanks, Sheena. Yeah, extremely important and extremely poignant, especially in light of some of the things coming out of the inquiry this week. So in terms of keeping track of the epidemic, even at its early stages, a lot of focus was placed on modelling. So modelling from SAGE and SPI-M was heavily implicated, in particular in the decision to eventually instigate the first lockdown. One could argue that they were probably voicing this a little bit sooner than it actually happened. But this has attracted criticism from some quarters. So I wanted to ask Kit Yates, our mathematical expert here, was this emphasis on modelling the right way forward, Kit?
Well, you're absolutely right, Steve. Imperial College modellers predicted that the UK would see about 250,000 deaths in the absence of tighter measures. That was on the 16th of March in their infamous Report 9. And that report was widely credited with causing people to change their behaviour and eventually ushering in the UK lockdown a week later, as you suggested. Some people have indeed criticised the fact that that prediction never came to pass as an example of a failure of modelling. But of course, that projection induced reactions like lockdown, like behavioural change, which meant that to some degree became a self-defeating prophecy, which averted its own projection. Given that we've seen over 230,000 deaths with COVID on the death certificate so far, it isn't hard to imagine that we would have experienced up to 250,000 as a result of an unmitigated epidemic wave. Just more generally talking about modelling, every time someone interprets data, you're using a model, whether you acknowledge it or not. If you're doing good modelling, then you're upfront about the assumptions that influence the outcomes of your model. And if you don't agree with the underlying assumptions that someone's put into their model, then you should feel free to disagree with their projections. But to just critique modelling because it's a simplified version of reality, that's not a valid argument. That's the point of modelling. Modelling remains, for me, the best tool we have to predict the future, not just of pandemics, but in any situation. It provides us with this framework to formalise our assumptions about the scenarios that we're trying to represent and to suggest what might happen under different circumstances, under different policy options, for example. So for me, it's always a better way to use modelling than to rely on gut feelings or common sense or the wishful thinking, which sometimes I think characterised our decision making in the pandemic.
No, that's absolutely true, Kit. And of course, people use more than one model. I think it's important to point out as well, isn't it? It's just ridiculous to conceive of people discrediting it in such ways. And so we knew, and eventually we did see action in March. And through March, April and May, the country was in its first lockdown. There was a devastating first wave, even though comparatively few members of the public were actually infected. And of course, the dreadful situation in care homes is something that I think many of us feel extremely strongly about. But what really was devastating is the impact on our healthcare system and the way that people were looking after things. So I wanted to turn to Dr. Helen Salisbury now and ask her really, what difference could it have made if our understanding of airborne transmission had been more broadly accepted and understood by policymakers and importantly earlier? And Helen, really, what lessons do we need to take for the future?
Yes, I mean, I think it was very clear from quite early on in the pandemic that this virus was spread through the air, that if people were infected, breathed out, the virus went out on the air, and if people breathed in that air, then they could be infected. And it didn't have to be within 1 or 2 meters. It could linger in the air for quite a long time. There was a huge amount of emphasis in all the public health briefings about washing hands and wiping down surfaces when these were not the main modes of transmission. And what we should have been doing was opening the windows and sorting out ventilation or air filtration. And I mean, as health workers, we had just so much information given us of the right way to take on and put on and take off plastic aprons, but really no emphasis at all on the need for well-fitting masks. And that there was a real persistence of the wrong advice for really quite a long time. And I think one of the things that affects me is just how many people we lost to COVID, both staff and patients, through hospital-acquired infections, because that infection control that should have been from looking at air quality just didn't happen. And there was a lot of very inadequate masks that didn't stop you breathing in the virus. And so people died as a result. For the future, I mean, we don't know what will cause the next pandemic, and we don't know what its mode of transmission might be. It may well be airborne again, but we can't say. But what we do need is for governments and policymakers to listen more clearly to the science and to pay more attention so that they can hear what we need to do to stop the virus, whatever it is, spreading. And it may be that some of those things might be relatively expensive, like fixing buildings and fixing ventilations, rather than the really cheap things like washing hands and wiping down surfaces. but it didn't help that they just went with the stuff that was easy, because it didn't stop the virus spreading.
Thank you, Helen. And of course, you're right, it is expensive, but I think there have been cost efficiencies estimates made of these sorts of improvements, haven't there? And I just wanted to bring in Susan Mickey very quickly here to comment on that idea of having safe air in buildings, and because other countries are doing this very successfully, aren't they, Susan?
Well, it goes back to the question from the member of the public about when will this end, and Aris's response about the importance of vaccines. But the other part of that equation is all the things that can be done to prevent transmission that isn't just about vaccines, and clean air is absolutely essential. And top of that list is, get buildings, workplaces kitted out with the right kind of air purifiers, with policies for opening windows when it's not too cold. And other countries, as you say, Steve, are doing this with all public buildings and putting in legislation. Belgium's one of them that's done it very effectively. And not just the legislation, but the monitoring and the sanctions to follow up to make the legislation stick. And Helen mentions that it's expensive. Well, it is expensive to put it in. But if you look at the payback in terms of people's health, well-being, economic productivity, the reason other countries are taking this seriously and making air safe for people is because it does pay in the long run. So I just wanted to add in that extra bit about we can end this with vaccines and with these kinds of measures.
Absolutely, Susan. And we've all been in favour of vaccines plus for many years now. And I should point out that there are cheaper alternatives, things like Causey Rosenthal boxes, etc., etc. And there were pandemic preparedness exercises that looked at coronavirus outbreaks, and they did advise that you should assume aerosol transmission before you rule it out rather than moving on. So both Helen and Susan have mentioned the idea about healthcare settings, and of course our healthcare workers, or so-called other key workers, in inverted commas, did really bear the brunt of the risk, especially during 2020 when they didn't have vaccines available. So Dr. Benita Kane, as someone who worked on the front line, what has been the impact on this population, and what is the learning for the next crisis and how we deal with it?
Thanks, Steve. Yeah, key workers like healthcare staff and teachers and many others were badly let down. And this is all going to come out in the COVID inquiry, but we were not adequately protected. As we've heard, many frontline workers died. Many of us were personally affected by that. Many thousands still struggling with the long-term effects of COVID infection. And those very same people who we clapped for, who the public clapped for, many of them are now chronically ill, losing their jobs being dismissed on ill health capability grounds, with that very cruel double whammy of not having had meaningful access to potential treatments for the condition because there has not been enough investment in that side. And then, of course, each of those people leave a void in the NHS workforce. You can't just replace a consultant or a nurse easily. It takes years to train people up properly. And that puts a strain on the pressure on people who are remaining. So people who are still there are having to work harder and potentially burning out for that reason. So overall, it's had a devastating impact on our workforce. And when you talk to teachers and other frontline workers, it's the same story. And that's not even touching on the mental health impacts of what people had to deal with during that time. So I think the lesson for future crises can be summarized into very simple words, and that's precautionary principle. We knew SARS-CoV-1 was airborne, and therefore when SARS-CoV-2 came along, the maximum level of protection against airborne viruses should have been implemented to anyone in the firing line until there was evidence to the contrary. And we still need much better education about airborne spread, not just to frontline workers, the public at large, as well as that investment in clean air that we've talked about.
Absolutely. Thanks, Benita. Of course, it might have helped if our stockpiles of PPE hadn't evaporated. Helen, what about the situation in primary care? I mean, this must have taken a dreadful toll.
I mean, I think, as Benita says, we're lacking some of our workforce because they're not well enough to work. I think there's still an ongoing problem that we have in that there's an awful lot of sickness absence happening, which puts the pressure on the system because it hasn't gone away. I think most of us in primary care were saved the really awful emotional toll of looking after the very, very sick that some of our hospital colleagues had. But we have quite a lot of distress from our patients still, and patients who would really love us all to be wearing masks, and patients who are really, really angry if we want to be wearing masks, and quite a lot of confusion or mixed feelings going on right there. So it hasn't gone away. It's still ongoing. And I think there's also, there was some very difficult stuff that went with the way that general practice had to change to doing remote consultations during the pandemic, and actually most places completely changed back. But there was, for some reason, there was a lot of antipathy towards general practices as well, following the COVID pandemic. So yeah, we're still suffering the fallout from that.
Of course, that's completely understandable. Thanks, Helen. So thankfully, as desperate a measure as it was, the first lockdown did work. And then measures began to relax. And we had extremely low prevalence in July 2020. And it appeared at least some of the sacrifices had been worth it. But had it really gone away? So at this point, Independent Sage advocated for something that we term maximum suppression, and people have colloquially called that zero COVID in 2020. Why was that, Christina?
Well, first, zero COVID never meant eradication. It meant reducing cases to zero or very low in your country. And it was achieved by Australia, New Zealand, South Korea, Japan, among others. The point was it buys you time, right? It buys you time to develop a vaccine, to find treatments, to tackle infrastructure such as clean air, and to mitigate the impacts of waves, for instance, by putting in measures to support people in more deprived communities, to strengthen health and care systems. In early August 2020, our cases and admissions in the UK were lower than in Australia and Japan, but they controlled their outbreaks and we didn't. We could have. The countries who avoided their big waves until after they'd vaccinated their population have had about a third of our deaths, and will have far fewer cases of long COVID as well. The other benefit that we would have had from keeping our cases very low would have allowed for greater opening and fewer restrictions, as we saw in countries like New Zealand, South Korea, and Japan. Because if you have a really low number of cases, you can have a find, test, trace, isolate, and support system that can keep on top of it. And so you have very targeted measures instead of population-wide measures.
Thanks, Christina. That's such an important point, isn't it? And completely contrary to the idea that people just wanted lockdowns or wanted perennial measures and ignored things to the point we had to turn down the sensitivity on apps, for example. But Steve Riker, the argument about going back to normal, as it were, is because don't we need to balance the effectiveness of lockdowns and controlling transmission against its economic and other harms?
There are many people who are now trying to rewrite history and saying the real damage done by the pandemic was not by COVID itself, not by the infection, but the measures taken against it. And the evidence shows that's simply not true. A big analysis published in The Lancet in 2021 showed that those countries which went hard on public health and dealt with the virus had less of an economic hit because they could return to normality much more quickly. And actually, they protected civil liberties as well. And that's actually, that analysis was done before you factor in long COVID, you factor in the loss of people in the workplace, the numbers of disabled and so on. So the equation gets stronger and stronger and stronger as time goes on. Now, there is an important point, which is, yes, there are consequences. There are harms of those measures, and we should mitigate against them, and we never did. Indy Sage, for instance, argued for giving laptops to all school kids, universal connectivity, so people aren't isolated, more mental health support. That should be done, but if you get on top of the health issue, the other issues follow. So the key message, very simple message, it's go hard, go early, don't dither. And it was a principle honoured in the breach by our government.
Completely agree, Steve. Thank you. So now to Anthony Costello. Anthony, how should we have done this? How could we have improved adherence to self-isolation policies? And of course, as we've heard, save both lives and our economy?
Yeah, well, if you want to stop transmission and suppress the pandemic, you basically want to get all cases and contacts to isolate, or as many as you possibly can. And in East Asian states and many European states, they recognized that generous financial support was needed to ensure that people weren't afraid of not being able to pay the rent or feed their families or drug bills. And we spent amongst the lowest amount on sick pay amongst OECD countries. We spent just £54 million in the whole of 2020. Compare that with what the IMF estimate we spent on furlough business support and crony contracts for procurement, which came to £409 billion. That's £409,000 million. And add on to that £450,000 million spent by the Bank of England on quantitative easing to solve the economic challenge. And the consequence of not paying relatively small amounts on decent sick pay is that self-isolation was dismal. And across all the waves, just 1 in 5 people with symptoms sought a COVID test, and only 43% stayed at home for 14 days. So on top of that, you have a very poorly controlled pandemic, unnecessarily long national lockdowns. Remember, the East Asian states didn't have any national lockdowns. And the ONS survey showing now, just under 2 million people with long COVID, 41% with symptoms lasting over 2 years.
You're right, Anthony, absolutely dreadful. And so much could have been avoided. And we had that devastating second wave caused by the Alpha variant, which we'll talk about in a second. Schools were open then closed, but we did finally get our vaccines deployed, a tremendous achievement. And also we started to develop therapeutics. So Sheena Cruikshank, what have we learned about the need for rapid deployment of vaccines and treatments for the next pandemic?
Well, we completely proved that we can work together to rapidly deploy trials, volunteers, expertise to make and/or test drugs and vaccines. And that is an amazing achievement. However, what we do need is a long-term strategy. So we need to be planning far ahead for vaccines and therapies. We should be investing in multivariant vaccines that target multiple features of the virus, or mucosal vaccines that give a more durable immunity. And we should be retaining these excellent ways of working together to better streamline trials so things can get from the point of discovery into people much, much more quickly. We've excellent scientific expertise to develop vaccines and therapy candidates. But to do this, we need to have pipelines for developing these and capacity for manufacture in the UK. Our ability for rapid innovation has in many ways been diminished by cutbacks to infrastructure, such as the Vaccine Manufacturing and Innovation Centre, and funding and short-term thinking, taking away the opportunities for funding research into these areas. We also need to urgently address inequalities in access to therapies because the systems we've got now do not work well enough. We need a vaccine strategy that ensures we better communicate and advocate for vaccines to tackle the ever-growing void that Christina and Kit showed earlier in vaccine uptake, and particularly this void in certain communities.
That's right, Sheena, and different communities around this country make such a difference because it's clear very early on that this has been a pandemic of inequality. So, Dr. Zubaida-Haque, what can we learn from this devastating impact on inequality for the future and how we deal with this in things to come?
Thanks, Steve. You're absolutely right. We didn't start this pandemic on an equal footing. And there were significant racial, gender, and disability differences, those structural differences that existed even before the pandemic. And we saw that. We saw that different groups in deprived areas, among Black and ethnic minority groups, in multi-generational households, those who were in lower, insecure jobs without the protection of sick pay. We saw that those groups fared very differently in the pandemic and in such a way that there were very devastating impacts. Now, sadly, the government, although they had reviews, did very little, took very little action on those reviews. So I think what I'd like to say is looking ahead in terms of the lessons that we can learn First of all, I think we should be thinking of collecting better data, being transparent with that data, and linking that data to ethnicity, gender, and disability. Really important. I think, secondly, trust and engagement were huge factors. We've heard our colleagues, our panel members, talk about trust and engagement, but trust and engagement with the public. That's enormously important. And in particular, outreach with that public. And we need to consider that historically, there's been a lot of racial discrimination in medicine with public authorities. That's really important. Thirdly, we need to think about financially supporting people to stay safe and to stay healthy, and particularly in terms of employment. That was really important, another lesson that came through in the pandemic. And finally, I think better funding for preventative programs that deal with health inequalities. Those are just some of the factors that I think we need to learn to go forward.
That's absolutely incredibly important, Zubaida. Thank you. Thank you so much. So a lot of the time now we hear about living with COVID, because this apparently doesn't seem to be a problem, but we've had variants of concern, things like Alpha and Delta that we saw during 2021. Now we're in the age of Omicron. We often hear that this virus has lost its teeth. Aris, is that really the case?
Yeah, we do hear this. So the virus has become defanged, and unfortunately not. I mean, Omicron has proven to be less severe than the Delta variant, but this wasn't through some sort of inextricable evolutionary path to lower virulence. In fact, it's not descended from Delta, and Delta itself is still circulating at low levels in some parts of the world. What we do have is that most people have some immunity to the virus, so we have better outcomes on average. But for those that are vulnerable, Omicron is still a very dangerous virus, and that's just considering the acute outcomes. The long-term outcomes is a whole other story. And it's definitely possible for a more virulent variant to emerge. I think that's just something we can't predict. Future variants may be more severe than Omicron. They may be more immune evasive. And of course, as time goes on and the mismatch between what we have immunity against and the form of the virus continues to grow, unless we keep up with the virus in an evolutionary sense by having better vaccines, the severity of the virus on a population level will also continue to grow.
Sure, thank you, Aris. And the consequences of this, both acute and long-term, are profound. We talked a lot about long COVID. We won't talk about it again. But really, to keep track of all of this now, we're finding it incredibly difficult because we've lost our incredible data sources. And so our ability to monitor this and potentially the next pandemic seems to have been hampered. So, Duncan, what's going on? Is this a good idea?
Well, I think the one thing about the data is the data was communicated to scientists very quickly about the disease, and all the characteristics about COVID were available for modelers very, very quickly. I think it took longer for that data to be available to politicians in a way that could be easily understood. And I think that's something that Independent Sage helped with the process. But really, we did have amazing data for Public Health England and UKHSA. A lot of that was on the COVID dashboard. We had the ONS COVID infection survey, which was, a world leader. We now have the ONS COVID winter survey, but that's not as good as the infection survey. We also had huge amounts of open data in terms of sequencing data, so we could see the rise of new data come along, new variants come along. And one of the critical things is this data has been open source and available to everyone. And I think as soon as that data goes behind firewalls or has to be paid for, then the response will be diminished. And I think one of the reasons Independent Sage has been so good, it's been about interpreting that data and communicating that data. One excuse I think that's been used, particularly by politicians, is I've seen nothing in the data. And I think as soon as we can close that down, the openness of data is important. Finally, so we've got these cycles of resilience and efficiency. So in 5 or 10 years' time, someone new is going to come in and say, why are you doing all this stuff with the data? It costs a lot of money, surveillance information. But we have to remember these capabilities that we've built up take a long time to build up, but a very, very short time to lose. And let's not lose those in the name of short-term efficiency.
Completely agree, Duncan. Absolutely vital. So lastly then, before we move over to our final thoughts, Professor Stephen Riker, very briefly, did we get the behavioural approach right as a country? Did we do this the right way? Did we build the trust correctly?
Well, thanks, Steve. That's a very easy question. And the answer is no. In effect, the government distrusted people. They saw as a problem to be managed, to be shamed or threatened into compliance with huge fines. And actually, the public should have been treated as a partner and supported, as we've heard from Anthony and others, supported to adhere. And in the end, by mistrusting the public, the government lost the trust of the public. And that was crucial for an effective response. So no, they did precisely the wrong thing.
Thank you, Steve. Couldn't really sum it up any better than that. So I hope that we've covered as many different aspects of this pandemic as we possibly can, either in our public questions or in these vignettes that you've heard from our panel members. We will continue to try and provide the answers to your questions going forwards. But for now, I'll call this part of the briefing to an end, and I'll hand over to my co-chair. It's been my privilege to act as co-chair on this body for the recent times, Professor Anthony Costello, to just sum up thoughts on what happens next. Anthony.
Thanks, Steve. Well, the first thing I think we've learned from this pandemic is that health has to be in all policies. It's not just about vaccines and doctors and nurses. So we've heard through today, labs, data analysis, clinics, population and public health, health systems, the NHS, but then social and behavioral science, engineering, economics, law, global rules about patents, politics and leadership. And that's something that the inquiry is looking at. And, health is our most precious asset. Health at its most fundamental is about everything in our lives that's meaningful to us. And it's what makes our lives worth living. So for our families, our children, our social networks, we've heard a lot about how we need to build trust and solidarity. There's devolution, how to address poverty and vulnerability. So all of those issues have come up. The second thing is that all of those principles apply to other great threats. And the greatest global threat in the 21st century is climate change. And I hope that that's going to be applied in the same way. And of course, with climate change, there's increased risk of pandemics, because climate change means that animals move, vectors like mosquitoes move, and people move. They migrate and they travel all at speed. And so they're our highest security threat. And when people say, oh, it's the first pandemic for 100 years, we've actually had 3 coronavirus major global epidemics since 2000. And finally, I think what I've learned is that Indy Sage has taught us all about the value of sharing ideas and information within scientific groups. I've learned so much from one of my colleagues here every week, but also between the so-called experts and the public. We've all learned a huge amount from you, because your questions and concerns, we often haven't been able to answer very well, but they've raised issues that we hadn't necessarily always thought about. And I think this is a model for interaction in the future that will come up with other health crises. And as we said at the beginning, we shall try to respond quickly. If any new crises emerge, we could start this up again. But thank you so much for all your contributions, your questions, your emails, and your support on social media. We really appreciate it. Thank you very much indeed.
Thank you very much, Anthony. And this is it. I'm going to have to draw this final Independent Sage Friday briefing to a close. Thank you to everybody who has sent in questions since May 2020, to everyone who has watched the briefings on Fridays, to everyone out there who's helped the scientists here on Independent Sage to understand what concerns and needs were most pressing as we all experience the crisis, and how science and scientists could help with engaging with those concerns. Thank you to David King for being here today and for being the spark and for assembling a formidable team. Thank you to everyone in the Citizens Organisation who have helped to put the briefings on air and facilitate this unique and valuable conversation between scientists and the public. Thank you today to Ben and Manasseh. For nearly 3 years now, the experts of Independent Sage have been volunteering their time and their expertise, producing reports, providing media interviews, and holding these public meetings every Friday, then every other week, to share their knowledge and advice, to interpret the data, to listen to your concerns, to answer your questions. So thank you to all the scientists of Independent Sage for all of your enormous dedication and hard work that will continue when this briefing ends. I don't know a more selfless, thoughtful, and deeply moral group of people. You are all wonderful. All the Independent Sage reports will remain available on our website, and you can still keep in touch with Independent Sage on Twitter and our new Substack. Thank you, everybody. Goodbye from me, Alice Roberts, and from all of Independent Sage. Stay safe and keep well.
Thank you, Alice.
Bye.
Bye,
everybody.
Bye. Until next time.
Bye.